Thank you for joining me for this talk. My name's Dr. Rebecca Perry from Adelaide in South Australia, and it's my pleasure to talk to you today about right ventricular strain and the new AFI RV package from GE. A big thank you to GE for the opportunity to talk today. Here are my disclosures. So before I talk about this new tool and how to use it, it's really important to look at the evidence of why we would use right ventricular strain. Why would we take time out of our busy clinical day to measure right ventricular strain? So the first study I want to show you is actually a study using histopathology. So these are patients who were having a heart transplant, so 27 patients, and they had an echo prior to their heart transplant. Now, they measured the RV fibrosis in the free wall after the heart was explanted in the native heart. So you can see here in the image on the left that the highest right ventricular strain correlated with the least amount of fibrosis. And as there was more and more fibrosis, the strain was reduced. In fact, there was quite a linear correlation between the degree of fibrosis and the right ventricular strain, as you can see here. Moving on to another study using right ventricular strain in 117 patients undergoing left ventricular assist device implantation. They defined right ventricular strain as the need for right ventricular assist device or inotropic support greater than 14 days post. There were 47 patients, or 40% of the cohort, that actually developed right ventricular failure. They found that a right ventricular free wall strain, more impaired than -9.6%, was predictive of right ventricular failure. They also looked at Michigan risk score, which uses clinical and biomarkers to predict the risk of right ventricular failure, and found that the addition of right ventricular strain to the Michigan score gave the highest prediction of development of right ventricular failure post-LVAD, as you can see on the receiver-operator curves. In green is the Michigan score alone. In blue is the subjective right ventricular function parameters added. So these are factors such as fractional area change and TAPSE, and then in red with the right ventricular strain added. So red has the highest area under the curve and therefore is most predictive of right ventricular failure. In another study looking at right ventricular strain in 238 healthy subjects and a cohort of 642 patients. The patients consisted of 216 asymptomatic patients, 214 with HFpEF, and 208 with HFrEF. This was across 10 centres, so it was a multi-centre study. So they used the healthy subjects to determine a normal range of right ventricular strain. So normal right ventricular global strain was -24.5%, and the normal right ventricular free wall strain was -28.5%. And the lowest expected value was -17 and -19% respectively. They then used right ventricular strain to detect subtle abnormalities compared to the traditional right ventricular parameters, such as fractional area change and TAPSE. So the graphs that you can see here show the number of abnormalities found in the HFrEF patients on the left and the HFpEF patients on the right. Right ventricular fractional area change is shown by the blue column. TAPSE and S prime are shown in white, and RV free wall and global strain are shown in red. So you can see that the right ventricular strain was able to pick up many more abnormalities. So this has really important prognostic implications because we know that right ventricular failure is a predictor of morbidity and mortality in patients with left heart failure. Furthermore, in this study, right ventricular global and free wall strain were significantly linked to the symptomatic status of the patient. So here's an example of some research using RV strain in the detection of ARVC patients. As we know, these patients are often really difficult to diagnose. So this study used 34 patients with confirmed ARVC and 34 age-matched controls. You can see from the graph that a right ventricular strain cutoff of -18 was able to differentiate between controls and those with ARVC. They concluded that right ventricular strain was superior to conventional echo parameters to identify ARVC. So this is a study looking at the differences in right ventricular strain between patients with chronic versus acute pulmonary hypertension. So they took 45 patients who had a pulmonary embolus, which was diagnosed with CT pulmonary angiography, and matched them for age, gender, and pulmonary artery systolic pressure with 45 patients with pulmonary hypertension. They also included 116 patients with pulmonary hypertension that weren't matched to their PE cohort. So they assessed left ventricular end diastolic area, fractional area change, right ventricular free wall strain as well. So you can see on the receiver operator curve shows the different measurements that they used to distinguish acute from chronic right ventricular dysfunction or pulmonary hypertension. So you can see that a cutoff of minus 17.9 for right ventricular free wall strain, shown by the green line, demonstrated the largest area under the curve, even when compared to things like McConnell's sign, pulmonary vascular resistance, and pulmonary artery systolic pressure. So why is this important? Well, it's really critical for us to determine the difference in a breathless patient between acute PE and chronic pulmonary hypertension because of the treatment conditions. We also know that in patients with chronic pulmonary hypertension, they have time for their right ventricular free wall to adapt to those overloaded pressure conditions. So their strain is actually better than the acute ones because there's no time to adapt. This is a study in systemic scleroderma who we know are at higher risk of getting pulmonary hypertension than the general population. This study looked at 80 patients with scleroderma who had an echo performed at baseline and also at 12 months later. A right heart catheter was performed in patients only with a clinical indication. 11 of these patients had documented pulmonary hypertension. They found that right ventricular strain was impaired in patients with pulmonary hypertension compared to those without at baseline. Furthermore, the scleroderma patients without pulmonary hypertension had a drop in the right ventricular strain, which may indicate early changes of right ventricular dysfunction occurring prior to the development of pulmonary hypertension, but this remains to be seen. Still with pulmonary hypertension now, but with a meta-analysis on patients with established pulmonary hypertension and the prognostic ability of right ventricular strain in this group. This meta-analysis used 11 studies with over 1,000 patients with pulmonary hypertension in it. The studies that they used right ventricular free wall longitudinal strain or right ventricular global longitudinal strain as a predictor of mortality or pulmonary hypertension related results. The graph on the left shows the hazard ratio of the combined endpoint of mortality or pulmonary hypertension events. The hazard ratio was 1.22, indicating that a reduced right ventricular strain indicated a 22% increase in mortality or pulmonary hypertension events. On the right, we can see just mortality by itself, and the hazard ratio here was 2.96, indicating that right ventricular strain is quite predictive of events. So the last study that I want to show you is really timely because it's looking at right ventricular strain in patients with COVID-19. This is a study of 120 patients with COVID-19 with a median follow-up of 51 days. In this time, 18 patients died. In the upper panels, you can see on the left a patient with impaired right ventricular free wall strain who died from coronavirus, and in the right panel, a patient with preserved right ventricular strain who did not. In fact, they found a cutoff in right ventricular strain of minus 20.5% was predictive of mortality in this group. I'm sure there's going to be a lot more COVID-related studies coming out, but watch this space. Unfortunately, it's with us for a bit longer, I think. So now that we've got the evidence for right ventricular strain, why are we not using it routinely? And I think really the biggest issue is that there's not a dedicated package, or there's limited dedicated packages that we can use on cart or on the machine to measure right ventricular strain. So if we want a dedicated right ventricular package, we've had to take it offline, and not many places have time for that, particularly when you work in a busy lab. So it's not advised to use the left ventricular package, but some people have used that because the region of interest is too thick. The right ventricle is a much thinner ventricle for a normal person anyway. Also, it includes the septum as part of the calculation, and the guidelines actually recommend just using the RV free wall strain. So the new package or the new tool that I want to talk to you about today is AFI-RV. So it follows the task force paper, and I would really advise if you want to start using right ventricular strain, it's very important to read this task force paper because it outlines a lot of information that you need to know. One of the key things that it outlines though is that if you're not doing left ventricular strain routinely, then you shouldn't be measuring right ventricular strain. So one of the key things was to optimise the view. It's really, really important that we use a right ventricular focused view. So on the left here is a standard 4-chamber view, and on the right you can see an RV focused view. Why is this important? Well, you see more of the right ventricular free wall. You see more of the distal right ventricular free wall in particular. And have a look at the differences in strain. So we've gone from an abnormal strain, potentially, to a normal strain. So this is the same patient and all we've done is focus the RV. This is where all our right ventricular measurements should be taken from, that RV focused view. So let's have a look at the tool in action. For anyone who's used the AFI package before, it's very, very similar. It's a three-click acquisition. So you can choose which beat you'd like to use, and then you just place your placement on the basal free wall and on the septum, on the RV side, and the RV apex. Straight away, it draws your region of interest, which you've got full control over to move. So you can see how you can change the thickness and you can change the placement. And very, very quickly, it gives you, first of all, your global strain and your free wall strain, but it also gives you your TAPSE measurement. So with any new technology, it's really about when will I fit this in? I'm in a very busy department. So the fact that it gives you your TAPSE measurement, you can already see that it will save you time because you're not doing that M mode for your TAPSE. You're not going into a different function. So not only do you get your TAPSE, you've got your right ventricular strain right there. It's semi-automated, so that improves your reproducibility as well. So just to finish up, I'd like to show you some clinical cases. So the first case I want to show you is a 31-year-old male who's a competitive athlete. So he had an X-ray because he had a hit to the chest, and he had an incidental finding of cardiomegaly on chest X-ray, particularly in the right ventricular area. So here's his echo on the left, and you can see that his right ventricle is quite big. So is his left ventricle, but you expect that in an athlete's heart. But how big is too big? He didn't have any TR to measure. He had a normal TAPSE, and his IVC was normal and collapsed fine. So are we worried about the size of this right ventricle? Well, let's have a look at the right ventricular strain. And you can see that it's perfectly normal. So it's the cutoff is -20, and you can see that it's -22% in the free wall strain here. So we're absolutely happy with this person. And this is a really lovely way of also following this patient up if they do need further studies. The next case I want to show is a 23-year-old male who had a recently repaired tetralogy of Fallot. He had RV dysfunction prior to surgery, and they want to have a follow-up of his right ventricular function now. So you can see that he is a congenital patient. You can see that the right ventricle's big, especially from that parasternal short axis view. And it's really difficult to determine what this right ventricular function is. He's got elevated or slightly elevated right ventricular systolic pressure. His TAPSE is abnormal. but his IVC is fine. So how do we follow up this patient? Well, right ventricular strain, because it's a talk on right ventricular strain. You can see that his right ventricular free wall strain is around minus 12%. Now, this is actually an improvement for this patient. So we've tracked this patient for a long time, actually, and this is how we've tracked his right ventricular function, using right ventricular strain, because it's the most reproducible parameter that we've been able to use. So for congenital heart disease patients, it's actually an excellent tool to use for tracking. So we use each patient as their own baseline, and then we track the changes with each echo study. So rather than tracking things like fractional area change, which has a lower reproducibility, or TAPSE, we're actually using something, a better tool for these patients. So the next case I want to show you is a 52-year-old female who had acute shortness of breath. So she required intubation on admission to hospital, and no one was able to get a prior medical history on her. So essentially they wanted the echo because they didn't know what was going on. So you can see here that she's got a big right ventricle and she's got abnormal septal motion. That much is clear. So we know that there's something going on in the right heart. Hugely high right ventricular systolic pressure. TAPSE is abnormal. And a big fixed and dilated IVC. And their question to us in ICU was, is this acute or is this chronic? So we took a measurement of the right ventricular strain, and you can see that the RV free wall strain is greatly reduced. So we concluded that this was an acute, and it turns out this patient had a big saddle embolus, pulmonary embolus. So this was a very acute case, and the patient actually ended up being treated, and they did quite well. Their RV function is almost back to normal. The last case that I want to show you is an 80-year-old patient with shortness of breath and non-pulmonary arterial hypertension. So she's treated. And I just want you to compare this to the case that I showed you before. So there's similar dilatation of the right heart, similar abnormal septal motion, similarly high right ventricular systolic pressures. Her TAPSE is a bit better, but you can see that her right ventricular free wall strain is actually much better at minus 17.7%. What was the cutoff we said before? It was minus 17.9, so it's pretty close to this. But this is a chronic where the right ventricular free wall has been able to adapt. These are patients that we also follow up with right ventricular strain quite regularly, comparing them to their own baseline. So what are the key takeaways from this talk? Well, I really hope that I've been able to show you that AFI-RV is really quick, easy and reproducible. That because it also includes your TAPSE measurement, you can use it instead of doing your TAPSE and save yourself a bit of time by keeping this much more extra clinical benefit. So you've still got your TAPSE, but you've got your right ventricular strain as well. And it's really important that it follows the consensus task force document from 2018. Thank you so much for your time.